Okay, then we can move on to the pathology of pulmonary embolism in detail. As I have said, the emboli may be of any size ranging from microscopic particle to massive embolism, massive embolus capable of blocking the main pulmonary artery or one of its main branches at the bifurcation itself. And that bigger emboli is otherwise called saddle embolus. And this may cause death within a few minutes because the blood supply to the lungs is completely cut off. That can occur within minutes, as there is no time for infarction to occur. If the size of the emboli is medium or moderate, it can move upwards, so that can be supplied to one of the lungs. So in that case the patient will survive. But if the emboli is very large, can directly block the pulmonary trunk at the bifurcation. So death can occur. This is one of the cause of sudden death. Many suspect it as heart attack or something like that, myocardial infarction or something like that. But it may be due to pulmonary embolism. So it is one of the cause of sudden death. Otherwise ഹോസ്പിറ്റലൈസ് ചെയ്ത് കിടക്കുകയോ അല്ലെങ്കിൽ വീട്ടിൽ കിടക്കുകയൊക്കെ ചെയ്യുന്ന പേഷ്യൻറ്റ് നമ്മൾ ആംബുലേറ്റ് ചെയ്യുകയോ അല്ലെങ്കിൽ മറ്റു ഫിസിയോതെറാപ്പി കൊടുക്കുന്ന സമയത്ത് നമ്മൾ നടത്തിക്കുന്ന സമയത്ത് പെട്ടെന്ന് പേഷ്യൻറ്റ് കൊലാപ്സ് ചെയ്തിട്ട് he will die within minutes. One of the reason of this presentation is, or the main cause of this presentation is pulmonary embolism. We can suspect massive pulmonary embolism. So that can occur within a few minutes in this type of massive embolism. Then in this condition there may be acute widespread pulmonary edema, then right ventricular hypertrophy. And when we come to lung infarction, these lung infarcts are particularly common with emboli of medium or moderate size that we have discussed. For anatomical reasons, the infarcts are more common on the right side when compared to left, more seen on the right side of the lung. And the lung infarcts are often multiple also. No, it's multiple occlusions in case of infarction usually. And about the shape of the infarct, it is usually triangular in shape, with the base of the triangle placed, or it is directed towards the pleural surface, and the apex of the triangle is pointing towards the hilum. That's a particular shape of infarct. Usually infarct is in the shape of a triangle. The base of the triangle is facing the pleural surface or directed towards the pleural surface, and the apex of the triangle is pointing towards the hilum. So it's very important when we take an X-ray. We can diagnose pulmonary infarction easily with the help of just X-ray. In that we can see triangular shaped opacity. If you are getting a triangular shaped opacity, the main DD coming is pulmonary infarction. So that's the shape of pulmonary infarct. Then the pleura in contact with the infarcted area. When an infarction occurs, the pleura in contact with the infarcted area, it will be covered with fibrinous exudate. And when we cut during surgery, when we cut the lung surface, the cut surface will be red or black. Then it will be firm, dry, and we can compare with pulmonary infarction with hemorrhage in the appearance also. Usually infarct is firm and dry, but in case of pulmonary hemorrhage, it is soft. Usually it is soft and it is moist. Presence of blood is there. It is usually moist and soft in the case of pulmonary hemorrhage. Then macroscopically, during the microscopic examination, the alveoli are packed with RBC, or we can see RBCs in the alveoli. The alveolar capillaries are congested, and there is necrosis of alveolar walls also. So congestion is there with the necrosis of alveolar walls. And about the fate of infarct, the infarct usually heals by fibrosis within a few days or within weeks, and it leaves a scar, irregular linear scar. And there can be pleural effusion, which may be serous or serosanguinous. Serosanguinous means presence of blood can be there. And the immediate effect of thromboembolism is complete or partial obstruction to the pulmonary arterial blood flow to the distal lamp. That is the immediate effect. And the consequence of pulmonary embolism can be hemodynamic consequences or respiratory consequences. And regarding the hemodynamic consequence of pulmonary embolism, there is reduction of cross-sectional area of the pulmonary arterial blood. This causes an increase in the resistance of blood flow that we have discussed. Resistance of blood flow, which lead to pulmonary hypertension or acute right ventricular failure. Then even a small embolus can have serious consequences in an individual with advanced heart disease or pulmonary disease. Or if the patient is having a previous heart disease or previous respiratory disease, then even a small emboli can be fatal or can produce serious consequences. That's about the hemodynamic consequences. Then respiratory consequences. It produces an area of obstruction leading to a zone of lung devoid of perfusion. So the blood supply is cut off, or the pulmonary supply is cut off to a particular area. So the particular area is devoid of perfusion, but there is ventilation. Air supply will be proper, but ventilation is not proper. So it can produce ventilation perfusion mismatch or ventilation perfusion inequality. In the affected lung zone, there is also constriction of air spaces. There can be constriction of air spaces or airways, and it can gradually lead to loss of surfactant also. It can lead to loss of surfactant. This may occur after some time, maybe after 4 to 5 hours, and later on lead to a condition called atelectasis or collapse of the lung. So these are the respiratory consequences. So the consequences of pulmonary embolism can be hemodynamic or respiratory. So that's about the pathology in detail. Then we can move on to the clinical presentation of pulmonary embolism one by one.